Bismillahirrahmanirrahim. I'm Dr. Ahmad Wahid Khan, a student of MPH. My supervisor is Professor Dr. Saira Afzal. Today, the topic of presentation is my minerals. Learning outlines. Introduction of magnesium, iodine, iron, and fluoride. Their sources, functions, and efficiency disorders, recent advances, and MCQs. Learning objective. At the end of the presentation, participant would be able to describe different aspects of magnesium, iron, iodine, and fluoride. Magnesium. Magnesium intracellular cation 20 gram per human body, 75% complexes with calcium. Daily dietary requirement is for men is 400 mg per day, women is 300 mg per day. Daily oral intake greater than 600 mg leads to diarrhea. Intravenous intakes more than 600 mg CNS depression. Magnesium, these are the magnesium rich foods. Magnesium dietary sources are cereal, beans, leaf, vegetables, fish. Absorption of dietary magnesium. Proximal renal tubule normal serum magnesium concentration 1.8 to 2.2 mg per deciliter. Ionized magnesium is 60%, protein bound magnesium is 30%, magnesium bound to other ions is 10%. Homeostasis is maintained by kidney absorption through carrier protein PTH, increase absorption of magnesium. Function of magnesium. Function as activator of enzyme alkaline phosphatase, hexokinase, fructokinase, phosphofructokinase, adenylate cyclase, CM dependent kinase. Decrease the neuromuscular irritability, play role in insulin sensitivity. Magnesium supplementation increase glucose tolerance. Magnesium deficiency decrease insulin depend upon uptake of glucose. Magnesium helps to control cholesterol levels. Function of magnesium metabolism, cardiovascular system include has a blood pressure lowering effect, reduce heart rhythm problem for muscles, inhibit the ability of muscle, reduce cramps. For nervous system, reduce the accessibility of nerve cells, has a calming effect. And in metabolism, essential for energy metabolism, important for protein synthesis. Magnesium deficiency. Hypomagnesemia, serum concentration of magnesium less than 1.7 mg per deciliter causes diabetes mellitus, chronic alcoholism, liver cirrhosis, protein, caloric malnutrition, diuretic therapy, hypocalcemia, hypokalemia. Deficiency of magnesium cause neuromuscular irritability, tremors, similar to hypocalcemia, carpopedial spasm, cardiac arrhythmia. Magnesium deficiency signs and symptoms, muscle cramp, muscle pain, osteoporosis, and fibromyalgias, headache, migraine, gastrointestinal disorders, fatigue, tiredness, high blood pressure, irregular heartbeat, and insomnia. Clinical sign of hypomagnesemia include neuromuscular muscle tetany, tremors, seizure activity, ataxia. Cardiac include electrocardiographic changes like peak T waves, mild ST segment depression, arrhythmia, ventricular tachycardia, torsade points, supraventricular tachycardia, atrial fibrillation, electrolyte hypokalemia, and hypocalcemia. Magnesium toxicity, if the level is between 1.7 to 2.4, normal serum level 5.5 to 8 cause nausea, headache, lightheadedness, and flushing. 9 to 8 cause absent deep tendon reflexes, hypotension. 12 to 15 cause atrial and atrioventricular block, muscle paralysis. hypoventilation, more than 15 cause cardiac asystole, respiratory arrest, and coma. Iron is one of the most essential trace element. Total body iron content is 3 to 5 gram, 75% present in blood. The rest is in liver, bone marrow, and muscle. Iron is present in almost all cells. Heme is the most predominant iron containing substance. It is constituent of proteins and enzymes. Hemoproteins, HB, myoglobin, cytochromes, catalase, xanthine oxidase, peroxidase, non-heme iron transferrin, ferritin, hemosiderin. These are the food which include high level of irons. Recommendation daily allowance adult men and postmenopausal women 10 mg, premenopausal women 15 to 20 mg, pregnant women 30 to 60 mg. Biochemical function of iron. Iron is a component of several functional important molecules. Iron is required for the synthesis of hemoglobin, myoglobin, cytochromes, catalase, and peroxidase. Cytochromes and certain non-heme protein are necessary for ETC and oxidative phosphorylation. Peroxidase, the lysosomal enzyme, is required for phagocytosis and killing of bacteria. Iron is also essential for the synthesis of non-heme iron compound like succinate dehydrogenase, iron sulfur proteins of flavoprotein, NADH dehydrogenase. Iron helps maintain mainly in the transport, storage, and utilization of oxygen. Iron is associated with effective immunocompetence of body. Iron transport and metabolism factor affecting iron absorption. Iron absorption increase iron absorption, vitamin C, citric acid, gastric secretion, hydrochloric acid, acidic pH. Decrease iron absorption, phosphate, TNA, tetracycline, EDTA, milk alkaline pH. Stage of iron. Iron store in the body 65% carried by the RBCs, 30% stored as ferritin in liver, bone marrow, spleen, 4% stored in myoglobin, skeletal muscle, rest in transit throughout the body, bond to transferrin iron binding protein. Ferritin is iron is stored in liver, spleen, and bone marrow in the form of ferritin. In the mucosal cell, ferritin is temporary storage for form of iron. Ferritin contains about 23% iron. Ferritin in plasma level is elevated in iron overload. Ferritin level in blood is an index of body iron store. Ferritin is in an acute phase reactant protein elevated in inflammatory disease. Hemosiderin, it is an other iron storage protein which can hold about 35% of iron by weight. Hemosiderin accumulates when iron level are increased. Ferritin is a protein shell packed with the hundred of thousands of iron particles. Hemosiderin is an aggregate of hundreds of thousands of ferritin particles plus amorphous protein and lipid. Both are supraparamagnetic and collected by macrophages, glial cells. Excretion of iron. Iron loss through feces, exfoliating skin, urine. Male 1 mg per day, menstruating female 2 mg per day. Person with marked iron overload 4 mg per day. Disorder of iron metabolism. Iron deficiency and iron overload are the major disorder of iron metabolism. Iron deficiency causes a reduction in the rate of hemoglobin synthesis and erythropoiesis. It can result in iron deficiency anemia cause. Iron deficiency is caused by inadequate intake, impaired absorption, chronic blood loss, and increased demand. Iron deficiency in anemia mostly occurs in growing children, adolescent, girls, pregnant, and lactating women. Symptoms of iron deficiency include microcytic hypochromic anemia, in which the size of red blood cells are smaller than the normal and have much reduced hemoglobin content, weakness, fatigue, dizziness, and palpitation. Non-specific symptoms are nausea, anorexia, constipation, and menstrual irregularities. About 2 billion of the world population are anemic. Anemia is more common in women and women. The prevalence of anemia among women is 29% of non-pregnant women and 38% of pregnant women. Iron overload, hemosiderosis, and hemochromatosis and iron poisoning are conditions associated with iron overload. Hemosiderosis is referred to accumulation of hemosiderin in liver and other reticuloendothelial system. There is no significant tissue destruction. Hemosiderosis is an initial stage of iron overload. Hemochromatosis. Hemochromatosis is a clinical condition in which the iron is directly deposited in the tissue like liver, spleen, pancreas, and skin. Hemochromatosis may be genetic or acquired. Genetic hemochromatosis, it is a hereditary disorder due to unregulated increase in the intestinal absorption of iron from normal diet. Iron is deposited as hemosiderin in liver, pancreas, heart, and other organs. After accumulation, excess amount of intracellular iron lead to tissue injury and organ failure. Acquired or secondary hemochromatosis, it is caused by excess intake of iron, increased hemolysis, and repeated blood transfusions. Hemochromatosis clinical features are related to the involved organ system as follows: liver leading to cirrhosis, pancreas leading to fibrotic damage to pancreas with diabetic mellitus. Skin includes skin pigmentation, bronzed diabetes, endocrine includes organs leading to hypothyroidism, testicular atrophy, joint leading to arthritis, heart leading to arrhythmia and heart failure. Iron poisoning, acute overdose mainly occurring in children may cause severe and fatal symptom due to toxic effect of free iron in plasma, which may be life-threatening. Symptoms are nausea, vomiting, abdominal pain, and diarrhea. Prevention of iron deficiency, iron supplement during pregnancy. According to WHO, 60 mg element iron and 250 mg folic acid daily for six months and additional 3 months in postpartum period in low prevalence country. Treatment of hookworm infestation. Single dose of albendazole 400 mg stat or mebendazole 100 mg BD for 3 days. Improvement of dietary habits. Iron rich food. Cook food in iron utensils. Intervention include iron fortification is very cost effective in areas of iron deficiency. It involves the addition of iron, usually combined with folic acid, to the appropriate food vehicle made available to the population as a whole. Cereal flours are the most common food vehicle, but there is also some experience with introducing iron to other vehicles such as noodles, rice, and various sauce. Prevention of iron deficiency anemia in infant and toddlers. Breastfeeding for the first 6 months of their life. Iron fortified infants cereal beginning at 6 months of age. Iron supplementation for preterm infants. Iron supplementation for breastfeeding infant at 4 months of age. Avoid cow milk before 1 year of age. Limit cow milk intake to 18 to 24 hours per day after 12 months of age. Iodine. Foods, age, age or population group. Recommendation iodine intake. This table shows the recommended dose of iron intake daily. Metabolism of iron. Iodine is absorbed from upper small intestine. Iodine is transported in plasma by losing binding to plasma protein. Iodine absorption also occurs through skin and lungs. 80% of body iodine is stored in the organic form as iodothyroglobulin in thyroid gland. Iodothyroglobulin contains thyroxine, tyrosine, triiodine. About 2 to third of iodine is excreted through urine, also excreted through bile and skin and saliva. Plasma iodine 4 to 10 mg per deciliter. Most of this is present as protein-bound iodine. Function of iodine include thyroid hormone synthesis, transport of thyroid hormone, interact major role in body's metabolism, including fat, muscle, and bone growth and breakdown, increasing heart rate, nutrient digestion and absorption. Iodine deficiency or disorder, low dietary intake include low iodine level in the soil and hence in consuming food, low consumption of seafood, economic restraint, inadequate utilization, presence of glycogenic glucose in food like cassava, cabbage, cauliflower, millet. What cause a goiter? When body do not have enough iodine, the thyroid work extra hard to make thyroid hormone, causing the gland to grow larger. Goiter food that inhibit the iodine uptake: broccoli, cauliflower, kale, cabbage, soybean, millet, cassava, Brussels sprout. Global Iodine Deficiency Disorder Prevention Days on October 22. How to prevent iodine deficiency? Number one, eat food rich in iodine. Take an iodine supplement. Have iodized salt in small amount. Level of prevention. Primary prevention include health promotion, health education, which include create awareness in high risk group, educate people to eat iodine rich food, salt and avoid nitrogen. Environmental modification include fertilizer, increase the soil iodide state, reducing iodine volatilization loss by limiting the soil. Nutritional intervention include food fortification, fortified salt, double fortified salt, spraying of potassium iodide solution on salt heap. Lifestyle and behavioral changes include difficult, slow, and gradual process. Avoid nitrogen, prefer iodine-rich food. Specific protection includes specific diet iodine level of iodization at the production level at consumer level. Supplement include iodized oil injection. 1 ml gives protection for 4 year iodine. Secondary prevention include early diagnosis, serum level of T3, T4, TSS, urine iodine excretion, heel prick test in unit for congenital hypothyroidism. Treatment is medically and surgical. Tertiary prevention include disability limitation, prevent the transition of disease from impaired handicap, dyspnea, dysphagia, dysphonia, surgery, rehabilitation, psychological support. Assessment of iodine deficiency with regard to the WHO global database on iodine deficiency and the measurement of iodine nutrition. Attention must be drawn to the following issue. It is important that each country carries out nationally representative survey on the regular basis. Iodine deficiency is the most UI is the most reliable indicator to access, monitor, and evaluate iodine status in the population at the assessment stage. Clinical detection of goiter may be useful, but it is also always be associated with the measurement of urinary iodine. Neonatal TSH screening may be useful if a reliable system is already placed and resources are available. Iodine control program in Pakistan. The iodine deficiency project was a joint effort between the government of Pakistan, UNICEF, Population Service Internationally in the early 90s. These three groups collaborated to tackle the issue which cause the health problems such as goiter, cretinism, stillbirth, and deaf mutism. About 20 million people live in iodine deficient areas of Pakistan. Of these, 88 million show some manifestation of iodine deficiency and at least a million shows some degree of mental retardation. Iodine control program in Pakistan, previous effort for fortified oil with iodide had been met with limited success. The next simplest option was a fortified salt with iodine successful, but still could not reach the rural population. Laborers at the salt processes plant with the technical abilities to iodize the salt. Instead of focusing on the harmful and negative aspect of the disease, the campaign choose to concentrate on positive images. Hand and port logo. The goal of the campaign was to increase the iodized salt consumption to combat iodine deficiency as well as to create demand for iodized salt through social marketing while also increasing the production. Fluoride, top, these foods are the top source of fluoride. RDA for fluoride infant 0 to 6 month 0.01 milligram per day. For 7 to 12 months of babies, zero point 0.5 mg per day. For children 1 to 3 years, zero point 0.7 mg per day. For children of age 4 to 8 years, 1 mg per day. 9 to 13 years, 2 mg per day. Adolescent adult male age 14 to 18 need 3 mg per day. Males over 18 need 4 mg per day. Females over 14 and need 3 mg per day of fluoride. Function of fluoride is formation of bone and teeth, helps make teeth resistant to decay, helps make bones resistant to mineral loss. Fluoride deficiency may cause tooth decay, susceptibility to infection, curvature of the spine, weak eyesight. Effect of fluoride toxicity, acute effect include nausea, vomiting, hypokalemia, tetany, hypotension, hypersalivation. Chronic effect include dental fluorosis, skeletal fluorosis, hypersensitivity reaction, dyspnea, gastric irritation, insufficiency of renal system, numbness. Fluoride toxicity treatment symptoms, symptomatic treatment, milk or egg can be given, lime water vomiting, so that majority of ingested fluoride is expelled in the hospital, cardiac monitoring, gastric lavage, general spot measurement. Recent advances. A review on experimental proven medicinal plant and their constitute against the fluoride toxicity. Fluoride toxicity, principally by polluted groundwater, is regarded as a momentous global public health risk as there is no particular and proven treatment for chronic fluoride toxicity. Fluorosis, which leads to several serious health complication. Scientific literature reveals several medicinal plant and natural product alleviate experimentally induced fluoride toxicity. The present review attempt to collect those experimental studies on medicinal plant and plant-derived natural product with fluoride toxicity ameliorative effect. Literature scrutiny was performed by using online bibliographic database and the studies for the last 15 years were considered. Minerals and the semi-synthetic or synthetic analogs of natural product were excluded. Later, literature study revealed that 25 medicinal plant and 17 natural plant products exhibit significant protection with from fluoride toxicity in the experimental animal models. Preclinical studies, two clinical studies on medicinal plant were also found in literature, showing beneficial yet poorly correlated outcome. Relevant research in the field could lead to development of potentially useful agent in therapeutic management of fluoride toxicity in the human MCQ. Question number one, diagnosis of iron deficiency can be complicated by concurrent infection since many markers of iron status are altered by infection. Which of the following combination of iron status markers is likely to be found in the person with both iron deficiency and severe iron infection? Option A is low hemoglobin, high ferritin, high serum transferrin receptor, high hepcidin. B is low hemoglobin, low ferritin, high serum ferritin reception, low hepcidin. C is low hemoglobin, low ferritin, normal serum transferrin receptor, high hepcidin. D is low hemoglobin, low ferritin, low serum transferrin receptor, high hepcidin. E is low hemoglobin, high ferritin, low hepcidin. Answer is A. Question number two, goitrogen is a food that inhibit uptake of iodine, resulting in formation of goiter. Presence of following vegetable in the diet can lead to the formation of goiter, except option E is cabbage, B is cauliflower, C broccoli, D spinach, and E is tomato.
E.
D is the right answer. Question number three, according to WHO, what level of urinary iodine is indicative of adequate iodine uptake? Option A is 100 to 199 gram per 1 day. B is 50 to 100 gram per one. C is 200 to 300 gram per one. D is 400 to 500 gram per one. Or E is 677 to 689 gram per one.
B.
A is the right option. Question number four, fortification of food with which of the following nutrient result in gut inflammation and diarrhea? Option A is iron, option B is iodine, option C is zinc, option D is copper, and option E is sulfur.
C. Zinc.
A is the right answer. Question number five is the best indicator for monitoring the impact of iodine deficiency disorder control program is option E is prevalence of goiter among the school children. B is urinary iodine level among the pregnant women. C is neonatal hypothyroidism. D is iodine level is soil. And E is neonatal hyperthyroidism.
E.
C is the right answer. Question number six, which of the following function as a natural medicine for cholesterol as it stimulates enzyme that lower the bad cholesterol and enhances good cholesterol? Options are option A is iodine, B magnesium, C iron, D calcium, and E sulfur.
A.
B is the right answer, magnesium. Question number seven, deficiency of dash increases the risk of poor glycemic control and diabetic retinopathy in diabetic patient. Option A is magnesium, B is iron, C iodine, D zinc, E sulfur.
A.
A is the right answer. Question number eight. According to WHO, dash provide the most effective assessment of the population iron status. Serum transferrin receptor, B is serum ferritin, C is the total iron binding capacity, and D is hemoglobin, and E is magnesium.
D.
D is, yes, D is the right answer, hemoglobin. Question number nine. A child was presented to nobody with a complaint of dental caries, curved spine, and a poor sight. The most likely nutrient deficit is in his diet is option A is magnesium, option B is fluoride, option C is iodine, option D is calcium, option E is sulfur.
Fluoride.
Yes,
D.
fluoride is the right answer. B. Question number 10. Which of the following supplementation protect organ and tissue damage through anti-inflammation and antioxidation? Option A is magnesium, option B is iron, option C is iodine, option D is copper, and option E is fluoride.
Magnesium.
Yes, the correct answer is E, magnesium. This is the key of all the MCQs. These are the references through which this presentation has been made. Here is the link of this YouTube channel. Thank you.